Okay. Yeah.
What do I press in here now? Says it's recording. Okay. Fine. Okay then. Good morning, everybody. I understand this is just before lunch, so bear with me. I'll try to make it as interesting as possible. For those of you who haven't met, I'm Nick Manny. I'm one of the SC6 in Doncaster. And I've chosen to discuss and talk about major trauma with you today. We actually do see quite a lot in Doncaster, believe it or not. And it's important that we all equipped in dealing with major trauma. Please ask me questions as we're going along. I don't want this to be just sort of an hour of me speaking. We have some cases that we will discuss as well. And these are cases that I've come across throughout my training, and hopefully we can all take away something from this. All right, so this is the structure of my talk. So I'm going to go through some general principles of major trauma, then we're going to talk about some specific sort of cases within different systems. And as I said, we'll go through some cases and we'll see how we get on. So I'm going to open it out to everybody in here. Just shout out. Okay. What do you think? What is the definition of major trauma? Just shout out. You can just unmute yourself and shout out. What is major trauma?
So when there's been a significant mechanism in injury with a high suspicion of problems with a patient that are sort of potentially life-threatening.
Okay, yeah. Anybody else?
Injury severity score over 15.
Okay, yeah. Anybody else?
Injury
Across.
system.
Sorry, say that again.
Injury to more than 2 systems.
Okay, yeah. Okay. Anybody else?
Injury that is potentially life-threatening.
Okay, good. Yeah. Yeah. Or is life-threatening. Yeah. Good. Anybody else?
I think we have a protocol to call the trauma team. So if we know that protocol, so that's all the element of the major trauma fits in that criteria.
Yeah.
You know, so when we call a trauma team, so that's a major trauma. Of course, mechanism of injury, you know, the site of the trauma, the number of bone, and the injury severity score also.
Yeah.
Of course, the age as well, because in silver trauma, you know, the mechanism might not be correlated with the trauma. So yeah, absolutely. Thank you very much. Well done.
Yeah, absolutely. Thank you very much for that, Mr. J. So, and thank you for everybody who said it. Basically, you've said it all, you know, all of the things that major trauma is. Now, we've mentioned about the severity score, the sort of the injury severity score. Now, that's sort of more of a audit research tool, really. So you can still use it within practice, but as Mr. J says, if you want to hang your hat on something, then you can look at which time would you call major trauma. So if I go to, I'm going to just go to this bit because, just bear with me. Where are we? Here. Okay. So if you have a look at this, have you all come across this? So what we have is, this is the Yorkshire Ambulance Services, and based on the vital signs, level of consciousness,
We can't see what you are sharing, Nick.
Okay, yeah, just bear with me, sorry, apologies. Just bear with me. Sorry. It's just a bit of a technical issue. Let me, so new share. Okay, here we go. Sorry about that. Can you see now?
Yeah.
Yeah, you can all see that. Okay. Have you all come across this? If you haven't, I really recommend that you look at it. Okay. So the Yorkshire Ambulance Services, we look at different parameters to then decide who will fit into major trauma. And based on this, then they can make a decision as to where the patient goes. All right. So you can see they're looking at vital signs and level of consciousness. That's the step one. And if they satisfy this, then they should go to a major trauma center. Okay. Now, if they don't satisfy that, then you come down, it's to do with anatomy of the injury. Again, if they satisfy any of those, then they can go to a major trauma center. And mechanism of injury is there as well as a step 3, and then there's a step 4 as well. I think Mr. J says there are certain patients you have to be careful about, like the elderly, pregnant ladies, and so on. Okay, so I really encourage that you look at this to get familiar with what would fit into a major trauma. All right, so I leave that. I'm not going to dwell on that too much and go back to the presentation. So let me go back to this. Okay, can you see my presentation now again?
Yeah.
Okay, fine. So how common is major trauma? What do you think? How common is it? Do we see it every day? Do we see it every other day? Does it depend where you are? What do you think? Again, just shout out. Anybody? How common is it? Or how many people die every year in the UK, at least, from major trauma? Approximately. 500,000, 10,000, what do you think? So 15,000 people die every year, all right, from major trauma, okay? It's a very common presentation, and it can lead to lots of disability as well. And of course, you know, it is one of those where sepsis and trauma are the big ones that we need to deal with. Now, if you look at this graph, I'm not sure if any of you have come across this graph. This is from ATLS booklet. So this is sort of a worldwide view of what causes major trauma. So, not surprisingly, road traffic collisions is sort of 1 in 4 major trauma. And there are other things as well, as you can see there. You know, it depends where you are. Of course, that chart will change depending on where you are. But this is sort of an average taken from the worldwide view of the cause of trauma. Okay. Is anybody surprised about this graph? Anyone surprised? Have you seen it before?
Yes, Nick, this other 17%, because, well, I surprised self-inflicted violence is quite high, and also the other, which about the other? Do you know this?
I don't know, actually. I don't know what the others are sort of are clumped into. I suspect there'll be loads of different things, but I don't know specifically. To
I mean, other might include burn. Is it? There's no burn there.
Yeah.
I'm surprised with the self-inflicted violence, 16% worldwide. So I'm surprised about that, because we're talking in major trauma. So how they will
me too, yeah.
I think so. So this is a very interesting point. So the things that I've seen, for example, when I was in Leeds before I came to Doncaster, I saw things like hanging, you know, things like somebody had stabbed themselves to kill themselves. There was another one where they shot themselves. There's various different ones. They can burn themselves, you know, there are all these different ones, and you know, these are then counted as a self-inflicted.
I think, what about the sport injury? Are they self-inflicted, or what? How we classify them?
That's an interesting point. I don't think you would classify it as a self-inflicted violence. I don't think. But that's an interesting point.
That might come in other, is it then? Other 17%. Yeah.
I think so. But again, it depends where you are in the wood. This is the HELS taking all the sort of, you know, all the figures and so on and putting it together. So in the UK, it's road traffic collisions, the majority. That's in the UK. So it's the same as what HELS will say. Now, not sure if you've seen this graph. This is a classic graph, which is very, I quite like it because this shows you why do people die from trauma. Okay, this is called trimodal of death from trauma. So you can see that those who don't make it to the hospital and they die at the scene, they've got a major catastrophic brain injury and they die. So, you know, their breathing is stopped, you know, and that's one of the sort of the first thing that happens usually. And they die from that. Now, for example, Princess Diana, I think when she had the accident in Paris, she had a very severe aortic dissection from the trauma. She did make it to the hospital, but she died shortly after. Again, cord injuries, spinal cord injuries. So obviously, depending on where it is. So if it's quite high, if you remember about C3, C2, 3, 4, I think it is, with the phrenic nerve, that would then, if I'm not mistaken, please correct me if I'm wrong, that's supplying your diaphragm. And if you get a high spinal injury up here, then you'll stop breathing, and also your blood pressure and heart rate will also be affected as well. So that's sort of out of the hospital. Obviously cardiac as well, tamponade and so on. So they would die, they won't make it to the hospital. And then you get this second wave, and this is where we want to catch the sort of the people there. We want to assess for these different injuries, and you can see the time as well. So you got 0 to 3 hours. Okay, so this is when hopefully they will make it to us, and we are able to assess for these injuries and able to identify them as quickly as possible and address them, which we'll come back to. Okay, and then later on, when they are admitted to, nowadays you have trauma wards, and sometimes they go to rehab and so on as well. But usually on a trauma ward, or if they go to critical care, they might have had a surgery, they go to critical care, they can die from multiple organ injuries and sepsis and so on. All right, but the one that we're going to concentrate mainly on today is going to be the one to sort of 1 to 3 hours. Okay, that second peak. Does that make sense? I hope that's made sense. Okay, so this is good to bear in mind. Does anybody have a question about this? Okay. So we've already talked about the clinical features. The clinical features are basically what I showed you with the ambulance crew. So those are the clinical features that the ambulance crew will be looking at for major trauma, and that's going to be same with us as well. But we're going to be looking at it at much closer detail. It's to do with the mechanism of injuries, to do with different vital signs, and also which part of the body or parts have been injured, and to what extent has it been injured. All right. So this is the way I like to look at it. You're looking at, and there isn't sort of the black and white answer to this. There are quite a lot of these that will fall somewhere in between, and you have to then use your clinical judgment. And if you're not sure, you need to ask. Now, one of the things to bear in mind is, if a trauma is called to your unit, the first question you need to ask is this injury beyond the capability of your center? If the answer to that is yes, then they shouldn't be coming to your center, okay, to the trauma unit. Now, I know that we get for example, open fractures in Doncaster, you know, the orthopedic will come and see, and then they send him to Sheffield because they can't deal with it. So ideally, you know, if you want to do it textbook way, they shouldn't really come to Doncaster. Now, sometimes you might find that, you know, a patient's got an airway issue, so they have to come to the nearest hospital to have the airway issue sorted before that they can then quickly go to the major trauma center. So that's the question you always have to have in your mind. Is the injury and the trauma that's presenting to you, is it beyond the capability of your center or not? Okay. So now we're going to get to the clinical evaluation. Okay, so let's say that you've received a call from a paramedic. They're saying that they're 10 minutes out with this patient who's a cyclist who's been hit by a car, and that's what they've told you. They're saying that they're 10 minutes out. Now, I haven't given you the other details yet, but how do you think you would prepare? What would you do? So the call is coming, you accept this patient, they are 10 minutes out. Anybody want to volunteer? So Mr. J has already alluded to one point.
I think when the paramedics give you a pre-alert, so they don't pull stuff out of the hat. So I would be concerning because they are the trained professional, and quite a few have worked quite a few years in dealing with the patients. One thing, and the second thing is because they are the people who are actually in a real time on scene of the trauma. So they have witnessed, bent cars and shattered, bonnet and everything, and broken bikes and everything. I think when they will pre-alert, so I would be worried about. I will be actually escalating and thinking about that,
Yeah, Mr. J is absolutely right. Now, the interesting thing is, though, Mr. J, when I asked paramedics, I've asked this so many times. I said, how many traumas do you actually see in a year? Do you know what the answer to that is? You won't believe it. It's 1 to 2 traumas, major traumas that they see a year. So you're absolutely right that they are at the scene, they can see what's happening, and they're making that decision. And obviously, if they've assessed the patient, they're telling you, this is major trauma, and it's not one that will go to the, a major trauma center. But because if it is, then you have to ask them, have you spoke to the trauma desk? Have you spoke to the MTC? But that's what it is. But as you say, you'll be worried, you'll put a trauma call out, you'll make sure that you've got everything ready. Anybody else? Martha?
Nick, you mean before accept the call, or just when you speak with the ambulance crew, or when they just to prepare to when they arrive to hospital?
So you've just accepted the call.
Okay.
And you're 10 minutes out. They're 10 minutes out. You've just accepted the call.
Okay,
So,
straight away, if I have that, I just also call the trauma team, organize the team to see that this trauma is coming, and I organize what is a group and safe, all the things that is necessary to do, and be ready, all the team waiting for the trauma. And of course, call the people that they need to be in the resource, no?
Yeah, absolutely. Anybody else? Yep, that's great. Anybody else? Do you want to think about anything else?
Other things would be like getting a trauma board ready, because we know we're going to move them across to them, letting the nurses know, getting any kit set up. So if we think there's a significant, injury, so if we think we're going to have to put a chest drain in, start and get some stuff ready in case we need it. Yeah,
absolutely. Yeah. Anybody else?
I would also alert CT that we are expecting the trauma patient, so they would be.
Yeah. So normally in a trauma center, when a trauma call goes out, so let's say at Northern General or in Leeds, at Northern General, I don't think it happens in Leeds, but at Northern General, when a trauma call goes out, radiologists will get alerted as well to that trauma call. And they'll bear that in mind and what's happening. And some of them, surprisingly, will come to the trauma as well. That's what happens sometimes at Northern General. They actually turn up to see what's happening because it's just around the corner from well, ours is around the corner as well, but yeah. Anything else?
I think in the trauma unit at Doncaster, you know, because it's a trauma unit, you know, people are not very up. But in the trauma center, absolutely agree. It's not just the radiologist. There are other components of the trauma team as well, which they are there. You know, there is somebody from the management side, so they will be accompanying the trauma team as well. Orthopedist, as said, you know, radiologist. Yeah, so you know, so and they have got a team structure. You know. So they've in the structure, somebody will be clinician who is managing the trauma, somebody will be acting as a runner, and the porters. Porters also are part of a trauma team because, you know, they are there as well. So it's quite integrated system in the trauma unit, really. Oh, sorry, trauma center.
Absolutely, absolutely, yeah, absolutely right. Now, this is the challenge for us in a trauma unit and in Doncaster is that we can get major trauma, but we're not quite set up for it, and this is sort of part of, hopefully is part of the fact that, you know, to make you all aware how you need to approach this, because there is a standard way of approaching it that hopefully means you know, you will cover all the points. Okay, so have you come across a 0-point survey? So this is a thing that Simon Cowley and who else was it? So Simon Cowley, the guy from EM Crit, I can't remember his name, came up with. So this is it's just a mnemonic called the step up. So when you get the call, you know, it doesn't have to be for trauma, but let's say in this case it's trauma. You prepare yourself, okay? So the S is for yourself. You're preparing yourself. Am I ready? What's happening? How many patients have I got on the go? You also, you know, try to stay calm and have a structured way of approaching it. Okay, you get your team ready, as we said. We've already mentioned. You put a trauma call out, especially at night when there aren't many people around. I would always encourage put a trauma call out early. If the people arrive, you know, and you don't need them, then you can send them away. You can ask them to sign in and you can send them away. And then we've talked about, you know, we'll have the resource ready. You know, if the resource is full, you've got to make a bay ready. You've got to have a trauma board ready and other things ready, as we've discussed. And then the patient will arrive. So this is your sort of 10 minutes. And as Mr. J said, you know, this is the important thing. Once the trauma team arrives, you have to be very clear. You have to say your name and you say that I'm leading the team and you're allocating different roles, okay? So this is sometimes before the patient arrives. So you can say to the anesthetic colleague, are you happy with the airway, and also check in the CS spine, make sure the immobilization is okay. You say to a general surgeon, are you okay to do a primary survey? The orthopedic person, actually the orthopedic colleague might be able to do the primary survey. The general surgeon might be able to put a line in. And you have to delegate these things, you know. If once you got the time, you need to delegate these things and have it all organized, all right? And you have to be very clear with your communication. So we've already
can I make a point here, because I think this is a very good point we are talking about. Now, in our trust, inherently, you know, I don't know why people are shy, because I've been talking this thing for a long time to the trauma lead. Can we not please put a little notebook in resource? I don't know what is the harm of combining the old and the new together, because I know we are symphony, whatever. So I think keeping a register, a little notebook in the resource where you write the D number, the name of the patient, the major trauma, and very important, the signing off this trauma team, because the trauma team comes, sometimes there's a haphazard, sometimes they don't come. When they come, they just walk about and research, they go away. I think their attendance and the signing is also very important. I don't know, I mean, I would suggest that one of our Caesar trainees should be buddying with the trauma lead. And because when they become consultant, being a trauma lead is a massive honor, and it attracts a lot of perk and a lot of what the other thing is, privileges. So I think being a trauma lead is a very good role of a AD consultant. So why not one of our Caesar training can be buddy with Firas is the trauma lead on ED, and and they can look into these sort of issues. So the TABA, because we don't know, people come, we don't know who is a orthopedics, who is the anesthetic. So sometimes I think I will strongly, as one of us trainee, can be a buddy to Firas, and they can look into these sort of issues. And of course, Nick has got I can see him. He's worked in quite a bit with trauma patient. He's got a very good, clear set of concept about that. So why not we get together and improve at least the trauma group of the patients?
Yeah, absolutely, Mr. Joe. I think we get, because of our catchment area, we get so many major traumas.
We do, absolutely.
And if we are not organized and systematic about it, then it's very, very easy for things to go wrong. Very easy. You will be very surprised. However, if you've got a standardized approach and it's consistent, so almost everybody is doing it, all the trainees coming through, we are teaching them, then it should be a very smooth process. It should be a very smooth process.
No, when we come to the case, I will, if we have a time, I will put in front of you a very, very recent situation, so you will be amazed how things go wrong.
Yeah, absolutely. And remember, we have the trauma booklet, okay? So you can get the nursing colleague, or you can go and get the trauma booklet and try to follow that, get everybody to sign in, as I said, assign roles. And sometimes, it might be helpful to even get stickers, but we don't have it at the moment, to say who is who and whatever. Anyway.
Nick, amazingly, we have a sticker.
Oh
God. What? If you ask the nurse, they will produce a big box of sticker.
Oh,
just experiment. Because we have everything, but we don't do it.
Well, this is the thing. So I think one of the things that we can do, for example, is simulation in situ. So simulation in resource, and that's something that can improve these kind of motions. Okay. So by the way, what I mean by simulation, I don't just mean within ED. So I mean, like on a Wednesday morning, usually different trusts, different centers, rather, different departments do simulation, because usually Wednesday mornings are meant to be sort of the downtime-ish for most of the departments. So if we do the simulation, we even put a trauma call out, and then all these people will come as well. And obviously we would have prepped them, beforehand to say we are doing simulation, so they don't just come surprised seeing a mannequin. And we can then run through all these motions, to improve all these different structures. That's what happens, for example, in places like Sheffield, in Leeds and things like that. They keep running these regular simulations to make everybody kind of ready and also familiar with equipments, with the situation, with paperwork, with all these different stickers and so on. But I think that's something we can come back to and speak about. And I'm sure it'll be very easy to set up, very easy, Anyway, so just in the interest of time, we'll keep moving on then. So Martha, Patrick, did you want to say anything? Sorry, you're on mute.
Sorry?
Is it Patrick?
Patrick.
Okay, I think he's talking to something else. Yeah, sorry. So Martha was talking about the trauma board. I hope you've all seen this trauma board that we have. Most centers do have this trauma board, and it's very useful. So you need to get this trauma board ready, ideally before the patient comes. Know where the pelvic minder is, know where various different equipment is. Try to have the ultrasound machine handy. As we talked about, delegate somebody to do the bloods and access for you, and the trauma booklet ready. So try to get as much things ready as possible before the patient comes, okay? So now, so this is a simple sort of cartoon to show you where people should be. So the team leaders should be at the end, okay? They shouldn't be getting involved with the survey, with the evaluation of the patient. It's like cardiac arrest, okay? So you are the team leader, you should be hands off, and you should have assigned yourself as a team leader. You should put your hands up I'm the team leader, my name is this, and that's it. If anybody else talks, you know, it has to go through you, all right? And what you will have is you have the anesthetic colleagues on the top, you have a doctor one who would be the assigned person to do the primary survey, you'll have a nurse one, you will have another person as well on the other side, I would say, you know, to get access and so on, whereas the nurse will be getting the monitoring and so on. That's how you should have it set up. And everybody else shouldn't be just around the patient and blocking the view and so on. They should be actually behind you, and they shouldn't be getting involved unless you say that I need this person, I need that person to come in or whatever. Okay, so you need that anesthetic, you need the doctor to do the primary survey for you. You obviously need a nurse to put the monitoring and everything on, and then you need this. You need another person to get access for you, and you're the leader. You know, if you start doing the access or whatever, you're going to lose the situation. Okay, so this is what it is. So that when the patient is brought in, you always have to ask. I've got a standard approach. So when the patient is going to literally is coming through to the door to resource, I ask the paramedics, is there any immediate issues? What do I mean by immediate issues? Do they have any airway problems? Are they bleeding? You know, is there any other issues? For example, you've just lost the central pulse or whatever, okay? If they don't have any of these issues and they're not concerned, then you shouldn't be talking to the paramedics. You should be telling them, I want the patient transferred onto the trauma board. Once you've done so, then what we will do is we'll do a hands-off handover, okay? So a quick hands-off handover where they can tell you very quickly as to what's happened, and they should be using the MIST, okay? So mechanism of injury, what injuries they're suspecting, what are the signs, what treatments they've given, all right? And then you can clarify, but that should be a very quick 2 minutes handover. So once they've told you that and nobody else has got any questions, and you ask about allergies of the patient as well, you know, anything else they want to know, one of them should go book the patient in, whilst then you start with your primary survey. And the first thing the second thing I then ask is anesthetic, are you happy with the airway? And also, are you happy with the immobilization of the neck? Because if you don't do these things, then you will forget. If they're happy with that, then doctor number one will carry on doing the primary survey, which we will come to. So the primary survey, we need to ideally have the patient completely exposed, but they have to be covered because we don't want them to get cold or anything. And the nursing colleague at the same time is putting the observation on, and hopefully if they don't have access, then somebody else will be putting the cannula in and getting access and getting bloods off, all right? Now, what are we looking for in primary survey? What is the point of primary survey? Okay, I've already alluded to with the graph that I just showed you all. You know, the trimodal of death. Okay, and I said it's the second peak that we're interested in, because that's when we can make a difference. So, have you come across this mnemonic called Atom FC? Anybody want to tell me what that is? What are we looking for? So when we are doing a primary survey, what are the conditions we are looking for? What are the injuries we are looking for?
It is A for airway obstruction, T for open pneumothorax, O for open pneumothorax, M for massive pneumothorax, F for flail chest and tracheobronchial injuries, and C for cardiac tamponade.
Okay, very good. Well done. Yeah. Okay, great stuff. Hopefully everybody heard that. Okay, so air is airway obstruction. Okay, that will become fairly, you know, quickly recognizable. And T is tension pneumothorax. Okay, O is open pneumothorax. M for massive pneumothorax, and you know, there is a specific definition for that. So if it's more than 2 liters, 1.5 to 2 liters coming out when you put a chest drain in, if you're suspecting that, or is 200 to 300 mils per hour for 2 to 3 hours. Okay, so that's a massive pneumothorax. Feral chest is not immediately life-threatening. Okay, you can argue. So, but you know, they put it there. And then cardiac tamponade, obviously, if they've been stabbed, usually it's a penetrating injury, usually it's not blunt injury, then that can itself cause shock, you know, hypotension, and that needs immediate intervention. So these are the ones that you have to immediately identify, apart from the frail chest, because you can't do much about it in the immediate setting. These are the ones you're looking for in your primary survey to then manage, you know, part of your primary survey. Okay, so obviously airway obstruction, the anesthetic colleagues will deal with that. Hopefully there'll be the tension pneumothorax, you need to decompress it, and now we don't decompress here anymore. Okay, we need to, don't put the needle in here anymore, we need to put the needle in the safety triangle. All right, so we're moving away from putting the needle there in the second intercostal mid-clavicular line. We're doing it in the triangle of safety. Okay, I'm talking about the cannula for decompression, and this is based on research because the needles are not long enough sometimes, you know, for certain patients, and also, you know, it's not an ideal place anymore. Okay, so we need to put it there. If it's open pneumothorax, we can just put a dressing over it. You know, they used to say put a three-way dressing over it, but now you can just you know, put a normal dressing over it and seal all the sides. You don't have to, it doesn't have to be a three-way dressing. Massive pneumothorax, which we'll come back to, because that's one of those ones where if you have put a chest drain in and you can see that the blood is pouring out, actually what you should, you know, they should have not been in your center in the first place, really, you know, in the trauma unit. They should have been in a trauma center, because then you've got a problem. They need a thoracotomy. They need an emergency thoracotomy. Okay, so some people say you can clamp the sort of the drain, but you know, if you're in Doncaster and you see that, then that's bad. That's really bad. I'm not really sure if you've got any clamshells, you know, to do thoracotomy, but it's not too difficult. But then what do you do after that? We don't have cardiothoracics or anything. They shouldn't be in your center. So if you were to identify it before you put the chest drain in, they should be immediately going to Sheffield. So you shouldn't be putting the chest drain in. Okay. Cardiac tamponade, again, you need a thoracotomy, emergency thoracotomy. Okay. So these are the ones you are trying to identify on your primary survey. All right, primary survey, you know, it's the same: airway, breathing, circulation, disability, and exposure. All right. So moving on then. Does anybody have a question about Atom FC, by the way, before we move on?
So what is this four-wheel thing?
Sorry.
Picture.
This is just the pictorial thing to say it's Atom. Yeah, it's just a pictorial thing to you know, it doesn't represent anything related to the trauma bit. It's just to say, you know, it's just a representation of Atom. That's all. But yeah, okay. So ultimately, the way we evaluate a trauma patient would be with once we've done the primary survey, we need to do some investigations. So the investigations that we do are very standard. So we get a VBG, okay? Now, I've seen so many times that when we get a VBG, the first thing people look at is HP. Is their HP low or not? Now, why is that wrong? Can somebody tell me? That is wrong. Don't look at the HP. Don't look at the hemoglobin. Can somebody tell me why that is wrong?
Because if they're
HP, I think one is we don't have the previous HP. It might be anemic, whatever. The second is might be hemo concentration, is it? You know, so I mean, yeah. So he's bleeding, fluid loss, hemo concentrations. You give fluid, then it dilute, then HB fall. Yeah. So I think it's not the first thing people should be looking at.
Anybody else?
Because it's the first. I mean, major trauma is a quick thing. It's not. Well, when you look at that, it's not how is in that moment the presentation of trauma, because the patient is the last things that is show that the hemoglobin is down. You know, that is not the real marker to show if, how much blood the patient lose. No?
Yeah, absolutely. So acutely, if somebody is bleeding acutely, the hemoglobin wouldn't drop. The thing that you want to be looking at is pH and bicarbonate and lactate. That's what you want to be looking at, okay? If the patient has become acidotic, then that's bad, all right? That will mean, well, one of the reasons it could be is that because they're bleeding, okay? So the HB might not go down immediately. And I think as Mr. J said as well, there are some issues about, you know, if they've had fluids or whatever, or if their HB has been down previously. But I think the main thing that I'm just saying, if this is a young patient, you know, who's been hit by a car, a biker, you know, I wouldn't be looking at the HB, you know, forget about that. I'll be looking at pH, bicarbonate, and lactate. That's what I'll be looking at, okay? Now, the other investigations, you do the, you know, FBCs, Usenis, LFD, clotting. You can do amylase and troponin, you know, for pancreas contusion, for cardiac contusion. You can do an ECG for those as well. You obviously do group and save. And these are the main things, really. You can do an ECG there as well. Now, nowadays, you know, we don't do kind of, you know, chest X-ray, pelvic X-ray, and a kind of a lateral CS spine X-ray anymore. You know, we'll just get a CT trauma, all right? It depends how stable the patient is. Obviously, if they're unstable, then as in hemodynamically unstable, they shouldn't be going to CT, all right? They should be either going to theater or the or interventional radiology, or you are doing something, for example, thoracotomy there, or REBOA, which I'm not going to go into, but REBOA is another sort of technique that interventional radiologists can use in resource to stop the bleeding. Okay, so these are the kind of the destination that you're looking at. All right.
I doubt we have a thoracotomy set in resource here. Clamshell thoracotomy.
We do have one. I know it's been used recently, and they argued that it hadn't been checked and it was out of date.
But that's again is equal to not having, is it?
Yeah, but they're planning to get it sort of checked all the time and make sure that it's it's stacked properly.
I don't know whether Dr. Reddy do simulation on trauma as well, because you know, thoracotomy is very, very rare procedure. But if we won't be simulating it, so people get hesitant and they go out after practice, I think we need to have some sort of system where it can be regularly practiced and rehearsed.
Yeah, absolutely. So I think Fahad was having a discussion one time about, you know, getting a simulation model and so on. So I think that's still in discussion.
Arranging that one, but then I mean, there was number of questioning was raising about that. Who is going to do this thing? Who is going to that thing? So I'm still in process, but let's see when I'll get it. Things.
Yeah, absolutely.
Thoracotomy is just cutting the ribs and flipping them over. It's not a massive stuff, and the patient is surely going to die because he's got a hole in the heart. So if we don't do it, he will definitely die. But if we do it, there are small chances that he will survive or she will survive.
It's 50-50, isn't it? If you do. No, okay. So I'm just aware of the time, so I just need to use some of the now. I think. And everybody go on mute, please. I think there is somebody who is not on mute at the moment. Okay, thank you. Okay.
Sikandar, it's yours. Can you mute
Sikandar's phone?
Okay, so based on so we've already said that there are some immediate life-threatening things we do need to manage there and then, okay? Now, other managements would be to give them tranexamic acid. So if it's less than 3 hours from the injury, you can give them 1 gram of bolus of tranexamic acid. And also you can give them, if your finger is bleeding, which we'll come to, in fact, is on the next slide, then you should really be giving them blood products, okay? So TXA, blood products, analgesia if they need it, which most likely they would if they are injured severely, anti-sickness, and keep them warm, because again, we're going to come back to why it's important to keep them warm, and make sure they are nice and comfortable, and also the airway we've talked about as well. So these are the immediate managements you need to be doing, and it should be fairly quick. Now, the reasoning I say that is because if somebody is bleeding, okay, you don't want to get into this, if they've got severe blood loss, then you don't want to get into this vicious cycle whereby the patient is getting cold, they are getting more acidotic, the clotting is going off, and this goes around and around and around, and the outcome of patient will become worse. So what you want to do is you want to, in order to sort of reduce the chances of this, you want to keep the patient nice and warm. You want to give them blood products, ideally, and you want to give TXA if there's any bleeding that can be stopped. And also there are other things like we talked about, pelvic binders, other splints, so Thomas's splints and so on, but there are certain splints which is like Thomas's splint that can be applied immediately. If there's any, if it's external bleeding, you need to put pressure on the site of the bleeding. So there are lots of things that you can do to reduce this vicious circle that will be going around. Now, there are common mistakes that are being made. So, for example, in trauma, there could be an elderly patient who turns up to ESA, for example. Let's say they are on anticoagulation. They've fallen from a couple of steps, and nobody really takes notice of it. So there's this concept of silver trauma, which just for the interest of time, I'm not going to go into, but essentially is these traumas which have been under triaged. They've been under triaged to sort of just a fall, for example, okay? The other one is to do with children, which again, we'll come back to, but children is a very specific one where you don't want to just be scanning a child. You don't want to just be putting them in a CT scan unless there are specific criteria that is, they meet, and it needs to be a senior decision really. Bleeding we've talked about. So bleeding is specifically is in the chest, abdomen, pelvis, on the floor, retroperitoneal, okay? These are the kind of immediate places you want to look at for bleeding. And we've already talked about the blood products. So ideally, you want to resuscitate these patients with blood products. You don't want to be giving them IV fluids. So these are the common mistakes people would make. They start IV fluids. I think if you really need to resuscitate your patient immediately, you need to start with O negative. And sometimes you need to put a major hemorrhage protocol out, for example, okay? I'm sure there are lots of other common mistakes as well people make, but at least these are the ones that kind of sprung to my mind. Now, we've already talked about some of these things. I'm going to go to this specific slide because you might have come across the CRASH-3 trial, which was very recently. So I've already mentioned about TXA to be given to patients less than 3 hours from the injury if you're suspecting bleeding. Now, recently they looked at traumatic brain injury as well. So CRASH-3 was specifically looking at head injuries and if there was a chance of TXA being beneficial. And what they found was, there are lots of external and internal validity issues with this study, but what they essentially found was that if you give TXA to a subgroup of patients, they might benefit from it. So these patients are the ones who have GCS of 9 to 12. The pupils are both reactive and they are less than 3 hours from their trauma, okay? You can give them TXA and it was shown to be beneficial. This was a randomized controlled trial. You might have come across it in your journal club. I've critically analyzed this as well when it came out 2-3 years ago. It's worth looking at this, but this was a subgroup analysis and there are lots of internal and external issues. I think they're trying to do more trials and more analysis to see if this is actually beneficial or not. So this is something to bear in mind, okay? Now, I'm gonna, just for the last 10 minutes, all right, we're gonna go through some cases, okay, before we finish off. Now, I want a volunteer to go through this case and tell everybody how they're gonna manage it, okay? So this is a 24-year-old man who's fallen off from the roof, and the paramedics are suspecting a head and a pelvic injury. He's confused and he's got, you know, he's shouting in pain, okay? So I want a volunteer to tell us how they're gonna approach this patient. Anyone? Otherwise, I will be picking on somebody.
Guys, you put yourself, you are working with me, and this is the patient, and I ask you, Prajwal, see this patient resus. So it's just think of a real scenario. So what you will do next? So you got the shies.
So if I was seeing this patient, so
yeah.
should I go into
Right.
research? So make sure we've got C-spine immobilized and they're onto a trauma board initially. I think potentially with him being confused and quite a lot of pain, I think I'd probably put a trauma call out with him, because if we're suspecting a significant head injury and a pelvic injury, I think it'd be worth getting them involved. We want to work through sort of an A to E assessment to see where we are. Want to make sure we get access in, bloods off. Want to get some observations on, see where we are, things like heart rate, respirate, blood pressure wise. Get our venous gas off, and sort of take it from there, I think.
No, absolutely. I think normally we should be aiming for, if we could do 2 gray vents on either side, because it looked like he might be having a significant bleed going on as well, especially with a pelvic injury and that sort of stuff, and the fall from height from the roof.
Anybody else?
My first question is, why is this patient coming to Doncaster?
Yeah, you're right.
They do.
Because the trauma, normally they say trauma desk refuse to take it. They won't accept.
You got
Marius, because in Doncaster, very good doctors, and they say, okay,
This was a real case. I saw.
I know. Yeah, I bet.
I saw at Northern. No. This wasn't in Doncaster, by the way, Marius. So this was a
Yeah,
real
I
case.
bet.
I saw at Northern General. So there was a guy who had been drunk. He had gone to his girlfriend. For whatever reason, he came out of the window of the attic, and he went on the roof, and then he fell down.
Oh God.
You know, completely fit and normal guy, and he had all sorts of injuries. I did a quick fast scan on him, you know, and he had blood in his abdomen. You can see his bladder was shattered. He had multiple injuries, and you know, these can turn up in Doncaster. It can. And the thing is, what you need to do is, you shouldn't be, if they turn up at the door, you shouldn't be turning them away, really, because if they're on your patch, you need to be bringing them in, doing a quick survey, primary survey. Okay, this is the etiquette of kind of, so that you don't get into the politics of, you know, the patient has just turned up at your door. Hopefully you would have deterred them away if it was an ASHI score. But if they've just turned up to your door, you can't be just saying, oh, you know, paramedics should be taking this one to Sheffield. You should be doing your primary survey, and then you should be picking up the phone and calling the trauma center consultant and saying that this patient is out of the capability of this you know, us, and we are packaging this patient to come to you guys. Okay, that's as simple as that. Okay, you should not.
I think sorry to interrupt, the trauma, because in general set of head is trauma surgeon or trauma lead is a surgeon somewhere with difficulty. Normally we ring the in these sort of patient, ring up the A&E consultant there at Northern General.
That's it. Yeah, the trauma consultant. Yeah,
for us, he is a de facto trauma surgeon, or whatever you can say. Because if you start ringing individual cardiothoracic, orthopedic, oh God, you are trapped. Just pick the phone up, ring a consultant at Northern General, and because they are like us, they've gone through all this situation. They understand what dilemma we are. They won't question too much. They will just say, yeah, please rush him over here. We are ready.
Absolutely, absolutely. So basically, that's the multi trauma. You know, if they're hypotensive, you know, you should just put some O negative. They give them TXA. You know, put a pelvic binder on them, splint whatever you can, and keep them warm. Package them. You know, call the trauma as consultant who is 24 hours there, 24/7 there now at Northern General in A&E, and just say this patient is coming to you guys. If they say to you, oh, do a CT scan in Doncaster or whatever, just say no, absolutely not. This patient is coming to you guys. This patient is in front of me, and this patient is not going to have a CT scan.
Sorry, Nick, they normally don't say that, because in my experience, they don't say that. I've spoken quite a few times. They say, okay, just rush it, you know. So the only thing is they would like to make sure that he won't have cardiac arrest on the way. You know, so just better stability and a right sort of team. The transfer of the patient is not, the accompanying patient is not an A&E responsibility. So transfer is always responsibility of the ITU or the anesthetic. Because sometimes the manager push you, general manager, oh no, you go or A&E go. No, not at all. Because this is across NHS, it's a routine that the transfer is done by the anesthetic and the ITU.
Absolutely. So another case then. So that was an adult patient. This is a child. Okay. Again, these are all real cases, by the way, that I've come across. Okay. This was in Leeds, which I've come across. So a 3-year-old who was actually part of the travelers community. He was on a quad bike with his older brother, and his right foot got caught in the chain, you know, in the quad bike chain, and actually was amputated. Okay, so then he came in. Okay, so that's what. So I want another volunteer then to tell us what do you do. So obviously this patient is saying that you've been told his foot is amputated. Okay, he's coming to you guys. Anybody?
First of all, like activate the trauma team. And what I would think about is like treat as an open fracture along with the thinking about the bleeding control to start with. So application of the tourniquet, IV antibiotics and tetanus shots to start with, and kind of resuscitate based on how much of the blood loss has happened. And basically more important is analgesics.
Okay. Yeah.
Suraj,
and involve the trauma team, basically. Trauma.
Sorry, when we children call the trauma team, we say, can we have because there are pediatrics in the trauma team. So ask the switchboard, is a children trauma, can you please believe pediatric as well? So because in hospital in Leeds or Sheffield, they call the pediatric trauma, what they call pediatric trauma team. But here we must ask the ped to accompany the trauma, and they would be down.
So can I just say something on this case? So the management, okay. So in trauma, if the circulation is an issue, so obviously if the child is bleeding, you know, from that foot, arterial bleeding, as you rightly say, you need to manage that before the airway. Obviously they're crying so that you're not worried about the airway at the moment. So you need to manage that. But remember, once you've managed that with tourniquet and direct pressure and whatever, you need to quickly go back to airway, breathing, circulation, and so on, okay? So don't be then thinking about tetanus, comoxicab, whatever. Yes, you will give those things, but once you've managed circulation, arterial bleed, whatever, okay, you need to go back to the CS spine, airway, breathing, circulation, okay, exposure, disability exposure, all right? These things are distraction injuries, okay? So the child is crying and everybody is concentrating on the foot, but what you might not see is that he's got something stuck in his chest, for example, or in his abdomen, okay? So you manage that. And the point from these cases that I've brought forward is to make sure that you all understand that do not be fixated on one area. You need to, once you've done the circulation bit, immediate management, arterial bleeding, then you go back and you do your standard assessment, okay, for trauma. And as Mr. J said, there are different people that need to be involved within that case. All right. So just in the interest of time then, because we just come to the end, I've got a few more cases which I'm not going to go through, but I hope that I've given you a bit of a sort of a flavor of major trauma. This is not a replacement for going on ATLS course or trauma course, and also for being supervised and getting those competencies and entrustment statements. You know, this is just giving you an idea as to what major trauma is, how do we do it. Essentially, there's a standard approach. This is what ATLS has tried to do for many years, and this is what we should be doing in order to hopefully not miss anything, and in order to reduce any risk to the patient. And you know, whatever injury they've had, it has happened. What we can do now is to address that and hopefully reduce any of the sort of impact on the patient, disabilities or anything else that could be happening. Okay, so what I would encourage you to do then is that to go away, read a bit about trauma, the different things. If you've not been on ATLS course or a trauma course, there's a European trauma course as well. You try to go on that, and hopefully we'll do some simulation and other things. Hopefully you'll get an opportunity to run a real case, you know, under supervision. You know, look at next time you're in the department, go and pick up the trauma booklet and see what's in it. You know, how does it work? And ask the nurses. I think Valerie is our lead nurse for trauma, if I'm not mistaken. You know, have a chat with her about it. And I hope that this talk has been useful. So thank you very much. Please ask me any questions you've got now. I'm aware of the time, but we can have 5-10 minutes discussion if people are happy to do so. I think you're on mute, Mr. J. You're on mute, Mr. J, I think.
Mr. J, you're muted.
Don't know what's happened with Mr. J. Okay, I'm not sure what's happened, Mr. J. He might have gone out. But does anybody else have any question about what we've gone through?
Nick, just to touch upon regarding the primary survey, is there a particular person to be alerted in terms of like, okay, surgeons do a primary survey, orthopedics come for secondary survey, but stay for any polytrauma involving the extremities? Is there any set criteria of who does what, or it just depends upon the leader?
So usually what I would ask them is that, so if I was to delegate, this is your responsibility to ask the person you're delegating, do you have the competency? You know, have you been on ATLS course? You know, are you competent? Are you happy, you know, to do the primary survey? Okay. But if they're not, so for example, in Doncaster, I had a situation overnight where I delegated the primary survey to one orthopedic sort of middle grade, if you like, and he wasn't happy. He was like, I haven't used the stethoscope in a long time, which is very disappointing, really, because you know they should have been trained in ATLS and so on. So, so the short answer to this is, it's your responsibility to make sure that you know the skill mix of your team, and you ask them to make sure they're happy to do that. Now, the secondary survey you alluded to, obviously that will come afterwards, and that's a head to toe assessment. And usually, you know, we end up doing that in A&E really to identify any other injuries. And I mainly focused on obviously the kind of the immediate major trauma management. I hope that's answered your question. Anybody else?
I was just trying to quickly touch base upon this particular thing that we have brought out, Nick. It's quite imperative that we actually do a small video learning session. If it may come from you, that'll be really helpful, involving what the booklet is like, and regarding what the setup of the trauma room should be like, and regarding what all should actually not come to Doncaster, because these are the things that need to be make sure that this has been agreed upon with the paramedics that these are not to come to A&E in Doncaster because of seriousness of the disease, of the injury, plus having a good airway rather than like crashing patient. Another thing is regarding what all medical equipments that is necessary and where are they located. Because if we do as a sim, most of us who are doing part-time can actually miss it. If we do as a kind of video, that is will be like everybody will be looking at that, and this can be disseminated to each one of us. And then once we have a look at the video, then everybody has got a clear idea. And then if we actually can go for a simulation session, some may attend, some may not attend, but at least they are aware of what to expect in their time of soft floor shift. What do you think?
Yeah, so I think these are the things that you need to have a discussion with Professor Zubaidi as well as Firas, who is the trauma lead. Okay, I think this is really something that you need to discuss with them, and I'm sure they'll be able to set up something. Now, you know, I mean, it's not that I'm not happy to do it. It's the fact that I've got lots of commitments and different things that I'm doing at the moment. So it's, you know, I can't spread myself too thinly, and I've got to be careful what I take on. So I'm sure they will be able to find another person, or, you know, Firas himself might be able to do that. And, you know, as you say, you know, there could be a video or something, you know, a talk, a pre-recorded talk. Now, the thing is, though, there's nothing to replace simulation itself, isn't it? You know, I understand you say there are less than full-time, you know, people there, but if we do keep repeating these simulations, you know, then hopefully you should be able to, you know, attend one of these ones. I hope that has made sense. Let me just close this one. Yeah, I hope this has made sense. So basically, it's important that we talk to the lead in trauma as well as Professor Zubaidi. Anybody else got any other question that they want to ask?
I was just going to ask, from sort of transferring out, so the ones that probably shouldn't have come to, say, Doncaster, and getting them across to a major trauma centres like Sheffield, how easy is it to do? Are they normally quite okay with moving them, or how does it work?
From Doncaster, transferring them out, you say?
Yeah, so, you know, when sometimes when they probably shouldn't have been there, if they're sort of significant injuries like that one you sort of said, would we sort of just try and manage them here, or would we try and shift them, so, you know?
No, I think as soon as it's a bit like if somebody's got a STEMI, as soon as you know they've got a STEMI, from you know, from the symptoms as well as, you know, the ECG, you call the PCI lab, exactly the same. Okay, so as soon as you realize, which should be fairly quick, you know, primary survey shouldn't be taking about 20 minutes. It should be less than a 5-minute thing, really. You know, as soon as you realize this, then that's it. That's you pick up the phone to the ED consultant over at Northern General. 24/7 they are there for trauma, and you say that this is, you know, you give them a very quick succinct handover and say that this is the patient I've got, I've done a primary survey, this is what I think is going on, and I need to transfer them out. If they've got any airway issues, the anesthetic should be able to just quickly, you know, manage that, and, you know, they might intubation or whatever, and then they might themselves need to go with the patient. But it should be fairly easy to do. There shouldn't be any resistance or anything like that there. You know, these are fairly clear cut, you know, on paper, and in practice, Mr. J was saying as well, you know, it shouldn't be too much of an issue to just call them and say, if they are resistant or whatever, then you have to escalate. You have to escalate to the right people. You know, whether it's the site manager or whether it's a consultant on call or whatever, then it needs to be escalated.
Nick, that is, sorry for that. Yes, you tell that we just do the primary survey, but then we don't do any other investigation, no? Or which investigation we supposed to do before
Yeah.
and before we
Don't be
transfer.
tempted. Yeah, I would definitely do a gas if you've got the time to do that. You know,
Okay.
but apart from that, I would not be tempted to do a CT scan or anything else.
Okay.
You can, if you wanted, you can do the
Blood.
EFAS. You can no. You can do the fast scan quickly if you wanted. You know, to give you a bit more information. But realistically, you don't really need to do anything. You've done the primary survey. You've addressed any airway issues, or if they're hypertensive, you might be having an O negative bag up and give them a TXA. But that's it. That's as far as you go. Okay. You
Okay.
won't do anything else. If there's a splints or pelvic binders or whatever that's required, then you do that as well. Anything immediate you do, if they need decompression, you know, tension pneumothorax or whatever, you do that. But don't be putting a chest drain, whatever. They should be going to, getting on the back of the ambulance and going to the trauma center.
Okay.
So
Okay, so don't be tempted to be sitting on a patient. That's what the temptation is. Don't be sitting on the patient. Okay, they should be in and out like a STEMI. They should be in and out of the department.
now one thing to remember that I've come across is that once you hang blood up, the paramedics won't transfer without a nurse or a doctor.
Ah, that's a good point.
So that if you start doing that, it's like when you get a STEMI patient that you start on GTN infusion, they need the nurse to go with them. So, and then it becomes a bit tricky. But ideally, like this kind of case of trauma that you're transferring out, you should be transferring out with the anesthetics, isn't it?
Yeah, absolutely. I mean, when you get into that point, the anesthetic, they should be going with them, and that's the protocol. You shouldn't be going with them or whatever. The anesthetic guys should be going, but there shouldn't be any delays. Okay, there shouldn't be any of the politics and delays or whatever. There shouldn't be any of that. It's the patient should be going. All right. Anything else? Because I'm aware of the time. It's I don't want to keep you from your lunch or anything else that you need to attend. But as I said, look, I'm not to cover ATLS for you or anything like that. This is just the overview of trauma and what it involves, and hopefully is sort of brought about some thinking from your side and what to think, how to think, where do you need to now go from here. And as I said, Firas, who is the trauma lead, and also Professor Zubaydi, you need to discuss it with those people, and also Reddy as well, college tutor, in terms of what your learning needs are and how they could be now, they should be able to then hopefully address all those and make a plan. Okay, so I'll leave it there. Is that all right?
Yeah, so